Hello viewers, welcome to my YouTube channel. My name is Sister Dr. Juliet Wangui Macharia. I am a gynecologist and a fertility educator and a medical management doctor. Currently, I'm based in Voi, working at Moi County Referral Hospital, which is also based in Voi. And I wish to extend my gratitude to all viewers and all those who have liked my videos, and more so to those who have subscribed. Thank you so much. I really feel humbled. And I ask you, when you view, please don't forget to subscribe and also share it out. Knowledge about health is very important. It is vital to our lives. So welcome again. And as I said earlier, I am a FEM doctor. That means fertility educator and medical management doctor. I deal with fertility issues, women with infertility, please. And most of those who are suffering from hormonal infertility. We have so many women who have turned to be infertile while they are not infertile. Infertility is managed and it is manageable. So don't die silently. Just visit us, and we, by God's grace, we were able to help you. Those women and girls with menstrual disorders, women with excessive bleeding, women with irregular cycles, women who are not ovulating. Remember, ovulation is a sign of health. Women who have suffered every month because of excessive pain during menstruation and even excessive bleeding during menstruation. Please pay us a visit, and we are here to help you. I have a clinic, private clinic at St. Joseph Shelter of Hope Town Clinic, and you can book earlier, and we are able to see how to help you. So today we are going to talk about one of the most common obstetric complications that women globally suffer from, and that is hypertensive disorders in pregnancy. It is a very common disorder, a very common complication, and we as gynecologists meet these patients in the ward nearly every day. And one of the questions I normally ask myself is that, why do we have the numbers increasing? The rate is growing very fast compared to how it was before. Is it because people are coming to the hospital? Yes, it can be. But again, it is an alarm that things are not okay. And every time one carries a pregnancy and you are able to journey all those weeks successfully, please don't forget to thank the Almighty. It is by His grace that has happened. So many women are suffering from obstetric complications, and what I'm going just about to share is all about that. So hypertensive disorders, these are complications that women encounter during the first trimester, the second trimester, and the third trimester. So when you talk of trimesters, the first trimester is all about the first early weeks, less than 12 weeks. Then the second trimester chips in, carries us until around 28 weeks, and then we finish up with the third trimester, and when the woman gives birth. So women with chronic hypertension. So when you talk of chronic hypertension, these are women who have been suffering hypertension. They are being managed or not managed of hypertension, but they had this disease prior the pregnancy. And because it is chronic, not acute, it means that the lady has been having this condition for quite a long time, or the condition has affected some of the very important organs, especially the kidneys and even the heart. That is why it is now chronic. So she may be under medication or follow-up, or sometimes because hypertensive diseases are normally very silent, and sometimes we tend not even to go to see doctors. We don't even want to go there. We just take medication on our own and we think that is okay. But chronic hypertension is a serious disease, and it needs a lot of follow-up and a lot of investigations so that you are able to, let's talk of being safe, health-wise. So a woman with chronic hypertension, and then she conceives, that means that this woman now, since she has conceived while having a chronic disease, then she might start getting these high blood pressures even as early as 6 weeks, 7 weeks, 8, 9, 10. Because pregnancy itself, any woman who is pregnant. So a woman with chronic hypertension, and she ends up conceiving, then already we have a risk factor in her body that makes her difficult to carry this pregnancy to term. Sometimes she may deliver well, but most of the time, these women in between, from the time she conceives until the time she delivers the baby, it's normally a very difficult moment. But how we wish this condition could have been managed prior. Okay, she has a chronic hypertension. Yes, it is a disease, but this does not make her not to conceive. What we are saying here is we manage this patient so that the chronic hypertension is no longer chronic. It has been managed. Yes, she has a high blood pressure, but they are well controlled. The heart has been checked. We have done an echo. We have done an ECG. The heart is okay. You see? So all these are preparation prior conceiving. But this is not what normally happens. Most of these women will come to us when it is too late to manage. And most of the time we tell them we have to terminate this pregnancy. It is not good. We also not feel good when we tell these women to do that. But for the sake of this medical condition that the mother has, and we have to save this mother from any maternal or even organ failure. So we end up terminating this pregnancy before the time reaches. This is under medical condition, whereby the team discusses and we end up saying, okay, let us save the life of the mother. But how we wish this could have been managed prior she conceived. So it is just a wake-up call to all patients who have hypertensive disorders, and especially those who know that they have chronic hypertension, they are under medications. Maybe you are even visiting the medical outpatient clinic. But before you conceive, please come to us. Please come to us. Some have got myths that the doctors might tell me not to conceive. But that is not the reason why we want to see you. We want to see you to prepare your body to carry this pregnancy without much complications. to make sure those organs which we think hypertensive might have brought some complications are well managed. And sometimes we make a very difficult decision when we find that the chronic hypertension, if you end up carrying pregnancy, things may be even worse. We might even tell you not to do so for the sake of your life. So that is chronic hypertension. But we also have a monster. I call it a monster because one of my teachers, a senior gynecologist, one told us while in class, my children, every time you see a mother with suffering from preeclampsia or eclampsia syndrome, always see death before you. I didn't understand what he meant, but now I do, because I have seen it. Any woman suffering from what we call preeclampsia, eclampsia syndrome. This is a high-risk patient that needs to be treated or monitored very, very aggressively despite her gestation age. To our mothers, remember this: if you ever suffered from preeclampsia, and let me put it in Swahili, uliambiwa wewe ulipata kifafa cha mimba au ulikuwa na pressure ya ujauzito, usibebe mimba kabla ya kumwona daktari. Na si daktari tu, It is not just a doctor, please. Because we visit, we are all speaking, but sometimes we visit, I don't know how to call them, but and somebody says, I saw a doctor. Yeah, we have different cadres. So make sure you visit, even if it's a health center, but somebody who understands. For those who are in Taita Taveta region, we have Mwatate Sub-County Hospital, we have Taveta Sub-County Hospital, we have Resu, we have Moi, and we also have some other private hospitals. Visit those areas. Those facilities will help you understand your problem there. Or anyone, any doctor or nurse, even in the dispensaries, that understands this. We may not know who understands and who does not understand, but listen to me, that if you ever suffered preeclampsia, eclampsia syndrome, if you ever suffered chronic hypertension and you are under medication, never conceive before visiting a doctor, either a medical doctor or a gynecologist or even a physician. Please don't. Because this is what has led to so many complicated issues in these women. Because they have a history, that they have a history of preeclampsia. The moment you have a history of preeclampsia, the risk, actually it is among the risk with a higher percentage. It has a percentage of 8.7%? So if you have a history of preeclampsia in previous pregnancies, then you have a risk, a percentage of 8.7 and above, I think up to 10, of getting it again. And when it comes back, it doesn't just come to you smoothly. I call it a monster. It comes with some complications issues, because when it hits you the first round, it left some complicated marks in you. Now it has come back even with a lot of force because the percentage is even higher. So the complications those scars which have to be managed before you conceive, but now you have conceived before healing these scars, then the percentage or the risk increases. If you go to another pregnant, the risk still continues to increase. That's why I concur with my doctor, with my teacher, my senior gynecologist, who told me that every time you see preeclampsia, eclampsia mother before you see death. He didn't mean that these women are going to die. What he meant, monitor this patient very aggressively, because this woman is laughing at one moment, the next moment is frothing. This woman has a high BP, you are talking with her, just a minute later she's conversing, and another minute later this woman is normal. So it is not as easy as we think, and that's why I call upon my colleagues. Let us not own these patients. If you are not sure of what you're doing, refer the patients. Even referring is a way of managing these patients. So we classify hypertensive disorders in 4 ways. 1, we have already talked about, is chronic hypertension. 2, preeclampsia, eclampsia syndrome. 3 is a preeclampsia superimposed on chronic hypertension. This means is a woman who had chronic hypertension at first. She was not managed. And then at 20 weeks gestation, she got preeclampsia. Now this is even more, these are bad news. So chronic hypertension and again preeclampsia. And the 4th one is what you call gestation hypertension. It is gestation because it occurs only, this is hypertension that occurs only when this woman is pregnant. So, and after pregnancy, we follow this woman for 3 months, that is during the preparatory period. We follow her up. And if it was really gestation hypertension, after 3 months, the hypertension is normal. But if it persists, then now we start thinking of another chronic hypertension, and she needs more management. So, what differentiates this? 4. Because every time you have the patient before you, you must be able to diagnose and come with the correct type of hypertensive disorder your patient is suffering from. So if she had this hypertension prior pregnancy, that is what we have already said, chronic hypertension. If she is 20 weeks and above, when you talk of 20 weeks, that's 5 months pregnant. So she's 20 weeks and above. And now she comes to you with high blood pressure of 140/90 and above. This woman comes before you, she has facial swelling, the fingers are swollen, the legs, what you call the lower limbs, are swollen, the abdomen is a bit distended, and when you touch it, there is what we call pitting edema. You try to push your 2 fingers or wherever, and you find that it is pitting. Yeah, it is full of fluid. So when you push, you are pushing the fluid away, and therefore there's kind of a dimpling. So when we see this patient before us, we think of preeclampsia. But what will make us diagnose it as preeclampsia and not gestation hypertension is the presence of protein in the urine. That's why every time you have a patient in the ward, make sure if you have diagnosed this patient with preeclampsia, eclampsia syndrome, you make sure you do urinalysis every day. So when we have presence of protein, and most of the time they say protein +1, +2, +3, that is an alarm. A pregnant woman may present with protein +1, but when it's +2, +3, then things are getting worse. This is more of preeclampsia. So preeclampsia, we define it as a pregnant specific syndrome. And the centerpiece of the pathology of preeclampsia is endothelial injury. Now, gestation hypertension, this is when we have blood pressure of 140/90 or even more, and it's in 20 weeks and above, but there's no protein. And this woman has been normotensive previously. That is gestational hypertension. When you talk of preeclampsia, this is when a woman presents with the high blood pressure of 140/90 and above. She has been normotensive before, and there is a presence of proteinuria. So the only difference between gestational hypertension and preeclampsia is that preeclampsia we have proteinuria, gestational hypertension we do not have proteinuria. You see? So with the chronic, it was before. So when this woman conceived, she had hypertension. But the two, we do not have hypertension before. Both of them, the patient has to be normotensive before the 20 weeks. But then we have the preeclampsia superimposed on chronic hypertension. So in this case, we have patient with the chronic hypertension, meaning that she was hypertensive before the 20 weeks. And then at 20 weeks now, she starts presenting with proteinuria and all signs of preeclampsia. So all these are what now we are terming as hypertensive disorders in pregnancy. And they are really, really bad conditions, obstetric complications that affect our women. So let's talk more of preeclampsia, because this is what I call a deadly monster. These women, when they go to antenatal clinic, they are all taught about signs and symptoms of those alarm signs that makes you to know that things are not okay and therefore I should visit the hospital. One of them is swelling, facial swelling. You wake up in the mornings, the eyes are swollen, the face is swollen, yeah, the fingers, the lower limb. Sometimes you find now, despite of the pregnancy, the abdomen again is distending, or you find it is swollen. And as I said, it has a pitting, and sometimes the pitting, the swelling can go even up to the thighs. So that is one sign. But two, when this woman now starts having easy fatigability or headache, the kind of headache this woman, most of women will talk about, especially those who have preeclampsia or impending eclampsia, they'll talk about a headache that does not go away, or it is a kind of a headache that she has never suffered in her life, because it is too painful, and even if she takes paracetamol or any analgesic drug, the pain does not go away. So it persists, and it's very severe. So that is another sign. But again, she will also talk of blurred image. She cannot see properly. Yeah, she cannot see properly. And because the preeclampsia normally affects the central nervous system, that's why she has all this headache, blurry vision. But sometimes when they normally get kind of confusion in one or another, but now this is in severe cases. This woman presents with the easy fatigability or sometimes with the difficulty in breathing because now the chest is full of fluid. Remember, this woman is puffy, yeah? So because the chest is full of fluid, you find that she has difficulty in breathing. And some of them may suffer from what we call pulmonary edema. It's one of the complications of preeclampsia, eclampsia syndrome. But they will also present with ascites. That's why the abdomen is swollen and the edema is everywhere. But they will also present with what you call oliguria. This means the level or the way they are urinating. They are just urinating very little urine, yeah? That is called oligo. Oligo means little. Uria means the urine. So oliguria. And if it's not managed properly, they may end up even being anuria. Means there is no urine completely. And this is a sign that the kidneys are shutting down or they have already shut down. So, but another thing this patient will tend to present, which is very common, it is what we call epigastric pain. Yeah, the pain at the upper abdomen. So they will talk of very severe pain. But actually, this is not epigastric pain as we may think. It is because the liver, which is at the right side, has been involved and it is swollen. And because it is swollen, you know, the liver, the way God created it, it is capsulated. It has got a capsule which protects it, like a sac, yeah? It's like a skin kind of, which has surrounded the liver. So when you have this condition, that capsule normally swells. So because it is swollen, so the liver is kind of enlarged in one or another. And because of that inflammatory issues of swelling, that pain tends to radiate to the epigastric. And that's why this patient will say that I am suffering from the epigastric pain. But is it really epigastric pain? You have to think twice. Another thing is that this patient, when we do the lab workups, they will normally have what we call thrombocytopenia. The platelet levels are very low. They are very low. When it comes to the pathology behind preeclampsia, we talked of endothelial injury. What is endothelial injury? All blood vessels are covered with what we call endothelia. So when we have the endothelial injury, these are injury of endothelial cells around the endothelium. And how many blood vessels do you have in the body? We have millions and millions of blood vessels, big and small. Now, when it comes to preeclampsia, it affects all of these blood vessels because it is, I said, the centerpiece of preeclampsia is endothelial injury. So all the endothelial cells all over the body have been injured. So when you injure the lining of the blood vessel, so there is kind of, we can simply say the blood vessels have got holes, yeah? And that's why there is fluid extravasation. The fluid is getting out. It's not supposed to get out. And that's the reason this woman, the edema we are talking about, it's in the face, the hands, the lower limb, the whole body. And remember, it's not only what you can see outside the skin. Even the brain is edematized. So there is edema in the brain. That's why these women sometimes suffer from very severe headache. And sometimes because of that edema and the high blood pressure this woman has, there is what we call the vasospasms in the brain, which tends now to lead up to convulsions. Yeah, and this woman, she had preeclampsia, which was not well managed on time, and then the severity of preeclampsia has led to eclampsia, and this woman will tend to convulse. Understand? So it is very interesting, and the bad thing about it is that you cannot tell who is who. One can have high blood pressure. We manage them the way we manage the preeclampsia, eclampsia, and she's able to conceive. She's able to deliver, and the mother is okay, and the baby is okay. But we have another one who the complications are too much for her, and you may get her convulsing, and we may even lose her if it's not well managed, or the severity of her condition is too much. So we have to be very, very careful when managing this patient. Now remember what I said, that every time you see preeclampsia, eclampsia patient before you, you see death. This is a monster. We have to treat it aggressively. Otherwise, our women are going to die, or they are going to suffer complications which may even make them not to be able to conceive in future. So that is one. But you have to also to understand that when these women come to us, most of us will rush for blood pressure, will check the urinalysis. But remember, not all patients who suffer preeclampsia, eclampsia syndrome have got high blood pressure, and not all have got protein. So what do we go for? We go for what we call investigating if this patient has got an organ failure. We have very important vital organs in our body. One is the heart, two, the liver, then we have the kidneys. So women who come with preeclampsia, eclampsia, it's not doing the urinalysis alone. You have to do the UECs. You have to see how the liver is functioning, and also the kidneys are functioning. So we do the liver function test, and also we do the kidney function test. We check the urea, we check the creatinine levels. These are the two very important levels in the while checking for eclampsia. So if you find that the creatinine level is high, you think twice, or it's raising. You will find that the urea is also increasing. Remember, any woman who comes with preeclampsia, eclamptic patient, and she's confused and all that, urea might be very high. That's why it's also contributing to that kind of confusion. So we have to check that. But you also have to check the liver function test, especially the enzymes, the transaminases, that they tell us a lot on how this patient is doing. But full blood picture is also key. We want to see the levels of platelets. Remember, because of endothelial injury which is happening in the body of this patient, there is, every time you cut yourself, the blood will tend to form a clot. So the same thing is happening inside your body, because there is injuries which you cannot see with your eyes. But this injury which is happening inside your body, every time the injury occurs, there is formation of a clot. And what forms the clot are the platelets. Now, the endothelial injury, which now is happening in all the blood vessels, taking place in all these blood vessels, meaning that your platelets levels will be overused. So because of that excessive usage of platelets, the platelets tend to go low. So if you find that when you do the full blood picture, and the platelet levels are low, that tells you that the endothelial injury, which is the pathology behind the preeclampsia, is real, and it has taken place. So we have to manage this patient. When you look at the theories of preeclampsia, the research has been done, and they try to explain more about the theories, which I'm not going to talk much about it. But we have what you call the placenta syndrome. And that is why any woman who comes with the preeclampsia patient, especially those who are eclamptic, the ultimate goal is to deliver this mother as quickly as you can. Yeah, some talk of 6 hours, others talk of 12 hours, but we have to deliver this woman as quickly as we can to get out the placenta. But remember, you may deliver the mother, but even after delivery, the preeclampsia, eclampsia can even continue occurring. This woman can converse. A woman can converse after delivery. So she can converse 2 days after delivery. So what we are talking here is dealing with these complications. When they come to us with the facial edema and all that signs and symptoms, they have difficulty breathing, yeah, and even to the baby, because the baby is not that safe. That's why sometimes the mother, the baby might die inside the womb, what we call intrauterine fetal death, because of the placenta insufficiency. Now, this baby suffers because of placenta insufficiency, which we'll talk in maybe 2 to 3 videos to come. We are going to talk about placenta insufficiency and what's all about it. So, this placenta insufficiency can lead to also what you call intrauterine growth restriction. The baby is not growing the way the baby is supposed to grow. She's at 30 weeks. We need the baby to be about 1.5, 1.6, around there. Now, but this baby has got 1 kg. Then we say the baby has got intrauterine growth restriction because of the condition of the mother, and that is preeclampsia. And in some cases, we normally lose this baby. And when we tell the mother we have lost the baby because of high blood pressure, some patients tend not to accept that. They say, my baby was very okay. Yesterday, I could hear my baby kicking me, playing around. How comes now you are telling me after 8 hours my baby is dead? That's not true. I don't know what and what. So it becomes a story. But remember, high blood pressure. That's why we do not monitor patients with preeclampsia at home. We don't. Sometimes when we come to Moi County Referral Hospital, we arrest them. We arrest meaning that we keep them in the ward. Let them stay there. Because while in the hospital, we are able to monitor them. While in the hospital, we are able to pick any complication. So we may keep them there. If she just have preeclampsia, she's nearly at term, we may keep them just observing them. If we need to deliver them immediately, we do. And even after delivering, we are always not in a hurry to rush this patient back home or to discharge these patients. We make sure we are discharging a patient who is fit to go home. And even if she goes home, we normally follow up this patient very closely. Sometimes after 1 week, sometimes they come after every 2 days, depending on how her blood pressure are behaving. So, my dear people, it's just to waken you up that any hypertensive disorder in pregnancy is not as simple or as easy to manage as people may think. But the good part of it, we can prevent these complications. We have mothers who once suffered from preeclampsia. We have mothers who lost babies because of preeclampsia. But they have been put on medication prior the pregnancy, and during the pregnancy, they have done what you call, they have been visiting the gynecological outpatient clinic. They have worked closely with these doctors. They have been seeing or monitoring their blood pressure, yeah? And because of that, every time we know that there's an alarm, we are able to intervene. So these women tend to give birth. Yeah, we even tend to prevent them from other complications because we are monitoring them very closely. Why? She has a 8.4 and above percentage of becoming an preeclamptic mother if we don't manage her properly. So we are keeping an eye to this woman because we want a live mother and we also want a live baby. So monitoring these patients is key. So any colleague or whoever are managing these patients, and you find a woman with such a history, you find that woman with high blood pressure of 140/90, or she tells you that she has been managed of high blood pressure prior, send her to us or send her to a sub-county hospital around you, because any sub-county hospital currently in Taita Taveta, we have gynecologists, we also have physicians, and we are able to manage this patient very closely. And in that case, we reduce the complications which might take away the life of the mother and also of the child. So thank you so much, viewers, and I am privileged, and I hope you have learned more about preeclampsia, eclampsia, and in a nutshell about hypertensive disorders. It's just to let you know that every time we see these women, let us make a follow-up. When they come to ANC antenatal clinic, let us make sure they come. Those attending Moi, those attending Taveta, those attending Mwatate Hospital, make sure they see a gynecologist, because we have gynecologists in Taveta, we have gynecologists in Mwatate, and we also have gynecologists in Moi, so that we are able to manage them. If they are far, sometimes we have calls all the way from Buguta, we have calls all the way from Marungu. These are nurses who have seen these patients and now they don't know. And when we talk about or we share more about this patient, we are able to see, is there any need to refer this patient, or what can this nurse do before she refers this patient? And the life of a mother in one way or another is taken care of in a very serious manner. So even giving us a call to consult is very, very important. Always remember that these women, at the end of the day, they are going to give birth. But these are patients who will suffer from what we call postpartum hemorrhage. This is PPH. They have a high risk of suffering from PPH. So always keep an eye, whether she has delivered spontaneously or through cesarean section. But remember, preeclampsia, eclampsia patient, we prefer to deliver them normally. So if she does not have any obstetric complications that will make her be taken to theater, please don't. Deliver her normally. It is more safe to deliver the mother via spontaneous delivery rather than through cesarean section if she has suffered from severe preeclampsia. But if she has obstetric complications such as non-reassuring fetal status, or a mother has got 2 previous scars, or the mother has got CPD, she's a CPD patient, there is no way she can deliver, then that is what you call obstetric complication. Now in that case, now cesarean section, there is an indication of cesarean section. And if there is no any indication of cesarean section, please monitor the blood pressure of the mother. Once the blood pressures are well managed, then deliver the mother, spontaneous delivery, or cesarean section if there is an obstetric indication for you doing that. And then after that, prepare yourself with what you call PPH bundle. PPH bundle is what we need during the management of postpartum hemorrhage. And then remember, keep your eye on that patient. If you have a monitor the patient. Remember, you have a patient, but a critical patient. She may be talking in 1 minute, another minute is frothing. Remember that. So let us be keen in managing our patient. We really love our mothers. We need them. They have taken care of us. We need to take care of them. So thank you so much, all viewers, for listening to my YouTube channel and also for subscribing. May God bless you, and may we continue to listen to these videos that they help us, they enlighten us about our health. May God bless you and stay safe. Thank you.